Welcome to this explainer. We are jumping right into a high-yield clinical gauntlet of anesthesia pharmacology. Now, this isn't just about rote memorization, right? It's about understanding the exact, precise physiological mechanisms that actually keep patients safe when they're in the operating room. So, let's put your knowledge to the test.
We've got four main areas to tackle today. First up, local and regional anesthetics. Then, intravenous induction agents. After that, we'll look at special populations and risks. And finally, we'll wrap up with complex clinical scenarios.
Okay, Section 1, Local and Regional Anesthetics. Let's get to it. All right, here's your very first clinical vignette. You've got a 70-kilogram patient undergoing a sebaceous cyst excision. The question is, what is the absolute maximum upper plane dose of lidocaine they can tolerate? Is it 210 milligrams, 490, 280, or 120? Go ahead and lock in your answer.
And the correct answer is 210 milligrams. The math here is absolutely vital. You see, plain lidocaine is capped at a really strict safety limit of 3 milligrams per kilogram. So 70 kilograms times 3 gives us exactly 210. Now, if you were to add epinephrine, that maximum safely jumps up to 7 milligrams per kilogram.
This actually perfectly illustrates a much wider pharmacological landscape. While lidocaine gives you that 3 milligrams per kilogram, you can never forget that bupivacaine is capped way lower at just 2 milligrams per kilogram. Why? Because of a really severe risk of intrinsic cardiotoxicity. Prilocaine, on the other hand, lets you push up to 6 milligrams, but then you're introducing the very specific risk of methemoglobinemia.
Let's zoom in on a fundamental concept for a second. How do these drugs actually stop pain signals right at the cellular level? I mean, obviously we know they cause numbness, but what is their exact molecular target?
Okay, so the absolute crucial point here is this idea of state-dependent blockade. These anesthetics actually cross the neuronal lipid membrane in an uncharged state. Then they ionize once they're inside the axoplasm. And finally, they bind to voltage-gated sodium channels directly from the inside, essentially locking them closed. This specifically targets and completely shuts down those rapidly firing acute pain fibers.
Now, if you're ever asked for the longest-acting spinal anesthetic, tetracaine is going to be your go-to answer over bupivacaine. Plain tetracaine gives you about 90 to 120 minutes, but if you add a vasoconstrictor, it extends out to a massive 4 hours for lower extremity surgeries and gives you a profoundly intense motor block.
Say you are reducing a Colles fracture using a Beers block. Your massive, cannot-miss exam pearl is this. Bupivacaine is an absolute contraindication, literally. Do not use it. If that pneumatic tourniquet happens to deflate prematurely, the bupivacaine will rush into the systemic circulation, bind super tightly to cardiac tissue, and virtually guarantee fatal ventricular arrhythmias. Just stick to plain lidocaine.
All right, moving right along to Section 2, Intravenous Induction Agents.
Let's tackle 3 clinical hurdles all at once here. We really need to evaluate our major induction agents against 2 major physiological threats: raised intracranial pressure, and cardiac instability. Okay, here is the breakdown. Thiopentone is your neurosurgical champion. It dramatically lowers cerebral oxygen demand and intracranial pressure, though keep in mind it does depress the myocardium. Now, for failing hearts, etomidate is totally your agent of choice because it offers incredible hemodynamic stability. And finally, ketamine is an absolute contraindication in neurosurgery. It spikes cerebral blood flow, which makes it incredibly dangerous if you're dealing with space-occupying brain lesions.
Let's talk about our most common agent, propofol. It's uniquely suited for continuous maintenance infusions, otherwise known as TIVA. But why is that? Well, its metabolic clearance rate actually exceeds normal hepatic blood flow. It utilizes rapid extrahepatic clearance in the lungs and kidneys, which guarantees a highly predictable recovery. It's a real game changer.
Which brings us to Section 3, Special Populations and Risks. Managing diabetic patients under anesthesia is notoriously tricky. So, which historically significant anesthesic agent is a huge red flag for someone with diabetes? Is it nitrous oxide, ether, thiopental, remifentanil, or succinylcholine? The answer is ether. We avoid it completely because it triggers this catastrophic neuroendocrine surge of counter-regulatory hormones, things like epinephrine, cortisol, and growth hormone. That surge risks profound hyperglycemia, severe glycogenolysis, and a massively elevated risk of DKA. And that right there is exactly why modern volatile agents like sevoflurane, which barely touch blood glucose levels, are vastly preferred today. Now, for our pediatric patients, particularly those between 2 and 6 years old, your primary goal for pre-medication is pure anxiolysis. Severe preoperative anxiety is actually directly linked to negative postoperative behavioral changes. We're talking night terrors and major pain amplification. So we counter that smoothly by using oral midazolam.
And if you get a scenario with a premature infant, say under 50 to 60 weeks post-conception, you literally have to monitor their temperature obsessively. Even mild core hypothermia depresses their already immature brainstem, which drastically worsens the risk of deadly post-operative apnea episodes. To prevent that, we prophylactically treat them with intravenous caffeine citrate.
Okay, home stretch. Section 4, complex clinical scenarios.
I want you to think really carefully about the mechanism here. You've got a 54-year-old patient taking chronic reserpine, and their blood pressure just crashes to 80/50 right during induction. Now, reserpine works by irreversibly blocking the vesicular monoamine transporter. That means the patient's endogenous neurotransmitter stores, their norepinephrine and dopamine, they are entirely depleted. So, which immediate vasopressor do you reach for from those options?
The correct answer is phenylephrine. Here's why. If you give an indirect sympathomimetic, something like ephedrine, it's going to completely fail. Ephedrine relies on displacing stored norepinephrine into the synapse. But remember, reserpine has already completely emptied out those vesicles. You absolutely must use a direct-acting agent like phenylephrine. It completely bypasses those empty vesicles and binds directly to the postsynaptic alpha-1 adrenergic receptors. That's how you safely restore their blood pressure.
Here is our final scenario, and it presents a really classic, debilitating postoperative complication. Imagine it's 6 months after a seemingly perfectly healed tibia and fibula fracture, but the patient develops this intense burning pain, hypersensitivity, and a blue cyanotic foot. What is the targeted treatment here? So, the diagnosis here is complex regional pain syndrome type 2, which historically was known as causalgia. Because there was documented trauma to a major peripheral nerve, in this case the peroneal nerve, it's specifically classified as type 2, not type 1. This whole condition is driven by a pathological, seriously overactive sympathetic signaling loop. You can't just throw narcotics at this and hope it goes away. The definitive first-line interventional treatment is actually breaking that abnormal sympathetic loop directly, and we do that with a paravertebral sympathetic block. As we wrap up this explainer, I want you to remember this quote. Mastering clinical pharmacology isn't just about passing board exams. It is about wielding precise physiological manipulation to protect the vulnerable. We've just seen exactly how drug choices have to pivot drastically based on things like brain lesions, failing hearts, or even just depleted neurotransmitters. So which of these active recall pearls actually changed your perspective today? And more importantly, are you ready to apply these exact molecular mechanisms to save lives?